Thank you for joining us today for our webinar. Today's webinar topic is going to be current CRC treatment options 101. So we want to make sure that you're getting a good background and update for many of you on what the current CRC treatment options there are out there for you. I'm Mike Morositz. I'm the Patient Education Manager at Fight CRC, and we're joined today by Dr. Cercek, who is going to introduce herself in a minute. But let's just get through a couple of our quick our housekeeping things before we jump in. So on today's webinar, for questions, please put your questions in the main chat panel. I know you'll see on Hopin, there's a little tab for you to use the Q&A section. Just please put them in the main chat. It's the easiest way for us to see them on our end. And please come with questions. We're gonna wanna be able to answer those that you have while you're watching the presentation. And as far as other webinars we've done in the past, check out our webinar archive at fightcrc.org/resources. You can see recordings of all the other webinars that we've done with many other topics that I'm sure you'll find quite interesting. And also tweet along. You can use the hashtag CRC webinar to get you and your community connected through the course of this and many of the other programs we have. Also, as far as our main resources that we have our flagship resource for stage 3 and 4 survivors, which is Your Guide in the Fight. We also have mini magazines, which dive into individual topics for you to gain more information and perspective to help you in decision-making. We also have our Beyond Blue magazine, rack cards, many other publications, you name it. Head on over to fightcrc.org/resources to check those out for yourself. And of course, the information and services provided by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you are ill, please see a doctor immediately. In an emergency, call 911 or go to the nearest emergency room. Fight Colorectal Cancer never recommends or endorses any specific physicians, products, or treatments for any condition. Okay, now we will bring you to the main event. We are again very pleased to be joined by Dr. Cercek here today. So would you please introduce yourself and tell us a little bit about the current CRC treatment options?
Sure. Hi, Mike. Thanks so much for having me, and thank you to the Fight CRC team. So my name is Andrea Cercek. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center, and I'm excited to be here to tell you a little bit about the recent updates in colon cancer treatment. So let me just share my screen. Bear with me, this is always fun. Can you see anything? Mike, does that look okay?
Yep, we're looking good.
Okay, excellent. Okay, so this is meant to be an overview. Please feel free to ask any questions either in the chat, and I will be happy to answer questions at the end. So the following are my disclosures. So just very quickly, as I'm sure most of you know, all of you know, colon cancer, really the staging is not determined by size, right? It starts in a polyp. And so what we look at when we determine staging is how deep the tumor goes into the lining of the intestinal wall, and then whether or not there are lymph nodes involved. And that's really how we determine staging. So stage 1 doesn't invade very deeply, no lymph nodes, no metastases. Stage 2 is sort of divided into 2A and 2B, and I'll talk a little bit more about that in the context of treatment. But basically 2A invades not all the way through, no lymph nodes involved, and then 2B goes all the way through, sometimes can touch other organs that are nearby, a bit more aggressive, but still has no lymph nodes. And then stage 3 universally just means that there are lymph nodes involved, and the number of lymph nodes determines sort of if it's stage 3A versus stage 3C, with 3C being a lot of lymph nodes, more than 4 lymph nodes, suggesting, you know, more aggressive disease, the higher chance really of this cancer having spread outside of the colon and the adjacent lymph nodes right next to it, making it then stage 4. So stage 4 means any distant disease, whether it's in the lymph nodes, the liver, or the lungs. With that, we have associated survival numbers. I'm happy to say that this is a bit of an outdated slide, actually, and this is now much, much better. And that, again, as I always say, you know, stage 4, not all stage 4s are created equally. It really depends on the person, the tumor genetic makeup, which we'll talk about in a little bit, the extent of disease, where it is, and what can be done. So this is why I don't like these statistics, even though they are still on my slide. So basically, treatment is based on staging. So stage 1, everyone does great. And most importantly, with stage 1, giving chemo doesn't make a difference. So there's very little chance of any microscopic disease, where if we give chemo, we can just cause all the side effects without any benefit. But survival and the chances of the cancer, survival is excellent, and the chances of the cancer coming back is very low. Stage 2 is a little bit of a gray zone. We look at high-risk features. We look at things under the microscope that suggest that the cancer might have escaped, like was the tumor initially perforated, meaning was there a little hole where the cancer might have actually escaped into the abdomen? Was there any signs of the cancer cells going into the blood vessels or into the nerves? And for those high-risk features, we generally recommend capecitabine and oxaliplatin, or CAPOX, now for 3 months. And this is really based on the IDEA analyses that were done very recently, where we looked at 3 months versus 6 months of chemo and found that 3 months of CAPOX are equivalent. If there's no high-risk features on stage 2, then we generally actually just follow patients. We used to give chemotherapy, but we've kind of reanalyzed the data and really don't see a benefit, but there's still this potential risk of long-term toxicity with chemo. And then stage 3, based on the IDEA data, pretty much universally, if a patient is able to take capecitabine, which is an oral version of 5-FU, and can comply with the treatment, we really recommend 3 months of adjuvant CAPOX now, or the alternative would be 6 months of FOLFOX. So that's the treatment for early stage disease. But we will take now a deeper dive into advanced disease and how we decide our treatment, and what's really important now in 2021 in terms of selecting treatment for stage 4 advanced disease. So the super important biomarkers that we talk about all the time that are really critical, and we really try to teach people, oncologists, et cetera, to check these as early as possible, because we do have treatment options based on a lot of these genetic changes. So the most important one is MSI, and I'll talk about MSI and the opportunity and the benefit of immunotherapy in this subset of patients. That they make up about 5% of all of our metastatic patients, but we've made tremendous progress in terms of treatment for this subgroup with immunotherapy. So it's really important to check the MSI marker even early on in diagnosis. As I'll show at the end of the talk, there is a benefit of first-line immunotherapy for this subset of patients. RAS is increasingly important. It's important because we know not to treat with certain drugs if the tumor is RAS mutated. But then recently, and I'll show this later on in my talk as well, one of the mutations, KRAS G12C, is becoming now, it's an active target. We have a drug for it, and it's actively explored in clinical trials at the moment in patients who have had all standard treatment options. BRAF, it's important. We know it's a bad prognostic factor, but also we've learned that targeting BRAF does help patients with BRAF mutations. And there are now studies looking at first-line treatment when patients are first diagnosed. And then HER2 is a little bit more of an emerging, but I think really exciting target in colon cancer. It's been around, of course, and studied extensively in breast and in gastric cancer as well, with really great improvements in targeting HER2. And now we're starting to see that in colon as well. So very exciting. So HER2 amplification is something that I'll talk about and that needs to be kind of checked early, hopefully, as well. So in terms of sort of the landscape of the colon and how we think about it, so this is your colon. The green, sort of the little round part of the green area, is the beginning of the colon of the right side, or what we also call the ascending colon. And it's ascending because it sort of goes up. A small intestine ends here, and then it goes up across. This is the transverse, and then down into the rectum. And this is the descending or left-sided colon. And we know that some of these markers that I just mentioned are expressed differently in different sides of the colon. So right-sided tumors tend to be more MSI high, not exclusively, but tend to be more MSI high. They tend to be more BRAF mutant as well as KRAS mutant. Left-sided tumors tend to have HER2 amplification and tend to be more RAS wild type. RAS matters a lot in terms of sidedness, and we'll get into this in a little bit further on, but we used to think that if a tumor is RAS wild type, it didn't matter if it was on the left side or the right side, but we actually learned that on the right side, even if the tumor is RAS wild type, anti-EGFR therapy, which is what we use for RAS wild type tumors, doesn't work. It really is limited to left-sided tumors. So that's why we talk about this left side versus right side difference, and prognostically it makes a difference as well. We don't really know why, but it seems that right-sided tumors tend to be more aggressive. Patients don't do as well. And so that kind of is an important part of our research, of course, and also when we think about treatment. So just sort of broadly speaking, if the tumor's on the right side, we tend to stick to more of a chemotherapy plus a bevacizumab or a VEGF backbone. And if it's on the left side, we can start with a chemotherapy and an anti-EGFR backbone if we so choose, or we can just do simply doublet chemotherapy to start. Oops. Okay, so what are the options? So I've sort of thrown some of these out already, but basically these are our drugs. So in terms of cytotoxic or sort of general chemotherapy, we have 5-FU, leucovorin, our oldest drugs, but probably still our best drugs because they universally apply to any location, any molecular alteration. Capecitabine is an oral version of 5-FU, irinotecan, and oxaliplatin. Those are our cytotoxic agents. Oxaliplatin does not work alone. We have to use it in combination with 5-FU. Irinotecan can be used as a single agent. Our VEGF inhibitors, really, there's a few on the market. I highlighted just bevacizumab. It's our oldest. It's been studied extensively. It's the cheapest at the moment. Aflibercept and ramucirumab have also been evaluated. They've also shown positive results, but never compared with bevacizumab. So we really can't say that one is better than the other. So we tend to stick to bevacizumab, but it's not wrong to use the other VEGF agents, particularly in second line or later. And then epidermal growth factor inhibitors, the target EGFR, those are cetuximab and panitumumab. They are very similar drugs. They can't be used sequentially, meaning if the tumor grows on one, the other one's not going to work, but they can be used one or the other with equal efficacy. And then for BRAF mutated tumors, as I mentioned, we have BRAF targeted therapy, and we learned very early on that just targeting BRAF alone doesn't work, that we need to use it in combination with another agent in the same pathway to really block what's called this feedback loop, where the tumors were sort of blocked in one way and then they started signaling another way to activate a different pathway. And so we learned that we had to block both pathways in order to make that work. But we've made quite a bit of progress in these tumors, which is exciting. And then, of course, MSI-High, I think the most exciting, as I mentioned early. For tumors that are MSI-High, we have both single agent PD-1 inhibitors. We have combination of CTLA-4 and PD-1, PD-L1 agents that work in the MSI-High setting after failure on chemotherapy, or actually in the first line setting as well. So those are the treatments, and this is kind of where they lie in terms of the timeline of introduction and of treatment. And you know, as I mentioned, 5-FU has been around forever and ever. Actually goes quite a bit this way into, I think, the 1950s, and then the newer agents on this end. And I will at the end mention also regorafenib and TAS-102, which have been approved as well after progression on all standard cytotoxic chemotherapies, really for prolonging survival, not so much for response, but they are perfectly acceptable agents that can be used as well for treatment of metastatic colon cancer. So what do we do in the first line setting? How do we start? So we tend to stick to a doublet or a 2 chemo backbone. So either FOLFOX or FOLFIRI. There's been lots and lots of studies evaluating these. Are they different? Are they equivalent? They really the bottom line is that they're equivalent in terms of how much they shrink the tumors, in terms of how long patients can stay on the chemo agents, or the time to progression, or what we call progression-free survival, meaning how long they stay on the treatment, as well as overall survival. And we really decide which one to use based on the toxicity. Oxaliplatin causes a cold sensitivity. It can cause a permanent neuropathy. We know not to give it for too long, but in patients that really need their fine motor skills, their dexterity, we may choose FOLFIRI up front. Irinotecan and FOLFIRI can cause some hair thinning. Sometimes people feel a little bit more like the chemo sensation for a bit longer. And many of our patients say, look, I just don't want to look like I'm on chemo. I don't want to lose my hair, and so we choose FOLFOX up front. In the United States, we've learned from studies that it's probably about 70-30, 70% of oncologists will choose FOLFOX and 30% choose FOLFIRI as first line, but that's really completely a dealer's choice. It's actually different in Europe. They tend to use more FOLFIRI up front. But for me personally, it's always a discussion, with the patients, although I do predominantly end up choosing FOLFOX. So the newer kid on the block, or the newer treatment option, which we see in other GI tumors too, but especially in colon, is what if we add everything together? So what if we give 5-FU-oxaliplatin and irinotecan? Does that help us? Does that help us in terms of response? Does that help us in terms of survival? And clearly, I think all of us would agree that adding everything together does improve response rate, right? And it makes sense. You're giving more drugs, you're attacking the cancer from multiple different ways, so there's better shrinkage. So in patients that are very symptomatic, or where we might try to give it our very best shot to shrink something to get them to surgery, that's a good option. In terms of sort of deciphering the data and really looking at the studies in detail, I won't get into that, but some of these patients that get this really strong chemotherapy up front then can't get onto the treatments later on. And so it's a little bit difficult to say whether or not survival is actually better, although some of the studies do show that. What we do know, though, is that more chemo is actually more toxic. And so, irinotecan causes diarrhea, as I mentioned, hair loss. There's more of a sense of there's more of an actual measurement of decreased blood counts as well with the strong combination, which makes sense. And I think this is important to keep in mind, because many people really with the best intentions try to kind of give combination strong chemotherapy. The person can take it. We can do this. Let's attack the cancer as best as possible. But we're seeing some emerging data, really, especially in our young patients, that first of all, they don't necessarily have less toxicity. We saw this from the recent analysis that the IDEA data presented at ASCO, where the patients in the curative setting young patients received more chemotherapy, didn't do any better with it, didn't have better outcomes with more chemotherapy, but certainly had more toxicity. And so I think that's important to keep in mind, because I think we mean well. We see a young person, we see a fit person, even an older fit person, and we want to give more chemotherapy, but it's not always necessary, and it can certainly lead to more toxicity, even in fit people. So it's just something to keep in mind. But again, depending on the individual patient, it is an option to give triplet combination therapy. So how do we choose? Do we give anti-EGFR? Do we give VEGF? We do have these available. I mentioned the chemo cytotoxic backbones, but then we have these biologics that people refer to EGFR or VEGF inhibitors as biologic agents, in addition to chemotherapy. How do we choose? So I think there's been a few studies looking at this, should we do bevacizumab VEGF therapy? Should we do EGFR therapy up front? Which is better? And I think the most important thing that we learned is probably from the CALGB study, and then subsequently from everybody else, that in patients that had, that we know basically that patients with wild type tumors do better with anti-EGFR therapy. But when we really tease this out to look at right versus left, which is what I mentioned in the beginning, patients with right-sided tumors, so these were all wild type. These were all, should have been eligible by all of our criteria and were eligible and received anti-EGFR therapy, they did terribly. So even though they were wild type, the drug should have worked, it should have benefited them. If the tumor is located on the right side, it didn't work. Whereas bevacizumab, really very nice overall survival for in terms of first line therapy. And then if you look at the right side with bevacizumab, again, as I mentioned earlier, right-sided tumors tend to be more aggressive. The outcomes tend to be worse, but significantly better than using anti-EGFR agents. This is where we really learned that sort of landscape that I showed initially of right versus left and what do we do. And then when investigators went back and looked at the other trials that asked the same question and saw the same thing over and over again with right-sided tumors really not responding to anti-EGFR therapy. So moving on to our next target, so BRAF. BRAF is an important target. It's about 9% or so of all stage 4 colorectal cancers. We know that it's responsible for signaling, for cell proliferation, for cell survival. And what we learned, as I mentioned in the beginning, is that when we first started looking at drugs that blocked BRAF, we did it in a trial with melanoma. In melanoma, with the same mutation, you give the one drug that blocks BRAF, and the tumors just responded, died off, great responses. In colon, there was this feedback mechanism where you block the BRAF mutation, but then it signaled back up to EGFR. So what we learned is that we really need to block both of these in order to shut off this entire pathway. And that's what these trials have really now looked at, and where this progress has really been made. And as I mentioned earlier, this is just a little graph showing that BRAF in general is a poor prognostic factor. These tumors tend to be much more aggressive. They tend to not do as well with chemotherapy. Of course, there are exceptions. It's not universal. This is BRAF V600E that I'm speaking about. And even in that subgroup, some patients do very well, but just the majority tend to not do so well. There are other BRAF mutations that are non-V600E where it's not clearly as aggressive, and the response is not clearly as bad as it is with V600E. So there's some nuances here with BRAF mutations, but specifically these trials addressed V600E. So this was the Beacon study. This was just the initial data. And in oncology, we always love these waterfall graphs. When they're falling, this like a waterfall, it means that the tumors are responding, the tumors are shrinking, and you can see these beautiful minus 80% shrinkage, meaning that's how much smaller the tumor is. And so this was really exciting. And here, the study was designed to look at blocking the BRAF protein, the BRAF mutation, as well as the EGFR, as I mentioned, and a MEK inhibitor, just to really kind of try to shut down that pathway. So it was 3 drugs in the initial safety lead-in. Super exciting data. And then this was kind of then moved forward into a larger study. And initially, the results clearly were much better than the chemotherapy arm. But when we looked at these numbers, the triplet did do better, but there was a lot more toxicity. And it didn't do that much better in terms of median overall survival and durable response rate. And this was when it was sort of updated, we really saw that the two were kind of neck and neck in terms of outcomes, obviously significantly better than the chemo backbone with just an anti-EGFR inhibitor. So based on that, this was approved by the FDA as a second line regimen in BRAF mutated colon cancer. And now the question is, can we do better? Can we take this into the first line setting? So these were patients that had already had chemotherapy where the tumors grew. And now we're investigating this in newly diagnosed stage 4 disease, with the question is, can we improve outcomes? The tumors are not pretreated. Will they be more sensitive to this combination, as well as combination with chemotherapy? So hopefully that will move the needle forward even more in mutated BRAF mutant V600E colon cancer. And then moving on to HER2. So as I mentioned, this is a newer target in colon cancer where we've made the most recent progress. So HER2 tumors, predominantly left-sided. They are not mutually exclusive with RAS or BRAF mutation. And why that's important, and I'll show this in a little bit, is because the tumor really needs to be RAS wild type in order to respond to HER2 targeted therapy. So it has to be HER2 amplified, not mutant so far, and with the studies that we've done, and RAS wild type. And so this were the initial studies. Again, exciting waterfall plots showing response in patients with a combination, so dual HER2 targeting with trastuzumab and a TKI in KRAS wild type HER2 positive metastatic colon cancer. So these are just responses, 30% that we're not used to seeing in patients who have been exposed to at least 2 lines of chemotherapy, where the tumors are what we call very refractory to treatment, and we try to give some novel combination. These responses are really quite impressive. And we saw this again with my pathway as well. And here's why, I was sort of harping on the wild type point, is because this KRAS mutant patients that were included on this study, only one responded, and actually it looks okay, one response, but really it was not durable. It was just, I believe, 6 weeks or so. And so not this robust response that we'd like to see, whereas in the KRAS wild type group, beautiful responses of 40%. And so Mountaineer is an ongoing study now, which we are also currently participating in, giving tucatinib, which is a HER2 TKI, plus trastuzumab. And this is just the patients. This is an older presentation at ESMO by Dr. Strickler. And just looking at the results, again, beautiful responses, overall response rate here in this study up to 52% in evaluable patients, median survival of 18 months. And again, these are patients who had progressed on all standard therapies. So just really exciting results. And especially seem to be a bit better when we look at the left-sided tumors. So there are other agents targeting HER2 as well, and deruxtecan is one of these that was also recently presented. Trials are ongoing in the first-line setting, in the refractory setting, and RAS wild-type patients. They are also looking at RAS mutated patients. This is a slightly different delivery of the drug. It can get into the cell, and so the thinking is that it could potentially bypass the KRAS mutation just by the mechanism of action, and it may not be necessary for the tumor to be RAS wild type, which I think would be quite exciting for our patients. It can also theoretically, because it's a different mechanism of action, work after growth on one of the other combinations that I mentioned that target the HER2 receptor. And so here again, the HER2 amplified, the very amplified tumors did very well with an excellent response rate in initial presentation. And then looking at the other drugs that I mentioned that have been approved since, I believe, about 2014, 2015, of regorafenib in refractory metastatic colon cancer. So this drug was approved based on improvement in survival. It didn't cause a response, which is why I stress sort of the excitement of the BRAF responses and the HER2 responses of 30%, really kind of blowing things out of the water, where, before we did see, while there was an improvement in survival, the drug does have benefit, particularly because of stability. So it is something that we offer our patients. It can cause stability, and sometimes what we think about it, if they're eligible for a clinical trial and it's not available, we might try regorafenib first, or we might do a trial, then go to regorafenib. Those are all sort of valid options and always in discussion with our patients. And I don't have a slide for TAS-102, but it's the same principle, very similar results in the refractory setting, and there are data supporting it with bevacizumab as well. And then exciting, KRAS G12C. This is very exciting. KRAS has been kind of the bane of our existence in GI tumors in general, and colon cancer. It's about half of our tumors are KRAS mutated, and G12C comprises a small proportion, a few percent of those, but of all comers, I should say. But there is now a drug, sotorasib, that targets KRAS G12C. Again, it had an excellent response in lung as a single agent, in colorectal. Same story, you'll see this repeat, not as good of a response, but we are now investigating it in combination, targeting the EGFR pathway, and those are ongoing trials that hopefully will lead to some exciting results. Certainly the preclinical data are quite exciting for this dual blockade. And here's my TAS-102 slide. Sorry about that. So as I mentioned, similar to regorafenib in terms of benefit. And then lastly, but certainly not least, mismatch repair deficient, or MSI, colorectal cancer. So this was, super exciting when we saw these beautiful responses in MSI-H tumors after progression on chemotherapy to single agent pembrolizumab, which is a PD-1 inhibitor, and you see a stark contrast in the mismatch repair deficient, the blue tumors, versus the mismatch repair proficient in terms of response. And we've learned that we've kind of showed this over and over again with pembrolizumab, with single agent nivolumab. Responses are durable, they're beautiful, and they're durable. And they are likewise great with combination of nivolumab plus ipilimumab, so dual blockade. Very strong responses, also durable, a bit more toxicity with the combination. Usually with immunotherapy, the toxicities are not at short term. There's no nausea, hair loss, things like that. But there's this possibility of immune related toxicities simply because the immune system is so revved up, and so we can see colitis, pneumonitis, hypothyroidism with either agent, but a bit more with the combination therapy. But again, excellent responses in combination. And then exciting more recently over the last year, we've learned from Keynote 177, which was a first-line treatment of pembrolizumab versus chemotherapy in mismatch repair deficient tumors, that patients with single agent pembrolizumab just did beautifully, significantly better than with chemotherapy in the first line setting. And this was recently presented in overall survival. It did not make statistical significance, but that's because crossover was allowed. So really it is a quite active agent in MSI-H tumors, which is why I sort of really want to bring home the point that it's very important to check these markers up front, particularly MSI-H, as we now have an FDA-approved immunotherapy option at the time of diagnosis. So I'm going to stop sharing. That's the end of my talk. Thank you so much for your attention.
Yes, thank you so much, Dr. Cercek.
I hope that wasn't too much. I try to.
Oh, it's good to have it all out there, and that's why we record these. If anyone wants to take another look and dive back in, they can always see it on our webinar archive on our website if they want to dive into something more specific, especially if they want to review it with their provider. So we did have a couple questions come in the chat, so I was hoping we could get to a couple of those quick before you have to leave today. So first one come in here is there a difference in treatment and OS between BRAF V600E with MSS and MSI-H?
Great question. Yes, that's a great question. So I didn't get into that. So there is a difference. We debate actually, if the BRAF MSI-H tumors equipoise at diagnosis, do you give immunotherapy? Would you consider BRAF targeted therapy? Both are correct. Neither one is wrong. We don't know whether one is better than the other. Between BRAF MSS and BRAF MSI-H, BRAF MSI-H do much better because immunotherapy works. And so that in terms of just overall prognosis, there is this big difference, but the nuances are kind of like, well, if it's MSI-H and it's BRAF, both options are available in terms of targeting the MSI or the BRAF, and both should be utilized if they need to be utilized. But immunotherapy really improves the prognosis of BRAF MSI over MSS for sure.
Great. All right, another one coming in is there a difference in left versus right-sided tumors between men and women?
That is a good question. Not that I know of. We've seen some reports that women tend to do a little bit better, that outcomes are better. We do see it a little bit more in some of the better prognostic markers. I didn't get into POLI. They respond to immunotherapy. They tend to be a bit more in women that and are on the left side. But I don't think that there's an actual number, to my knowledge, that's different between men and women, left versus right.
Okay. And then what does a VUS biomarker mean for my treatment? Is it actionable?
BUS?
VUS, as in Victor.
It's not actionable. Okay. I don't think we wouldn't base treatment options on it.
Okay. And then we just had a few big conferences, including ASCO. Was there any research that came out recently that you've been particularly excited about?
Yeah, I mean, this is kind of the points that I made. I think the first-line immunotherapy in MSI-H is really exciting. It's FDA approved. They just presented the survival data, which again, the p-value was really strict, and they almost met it, and the study allowed crossover. So I think there is definitely a benefit of immunotherapy in MSI-H tumors in the first-line setting. And then the one that I mentioned or alluded to a little bit was the IDEA analysis. So the IDEA were a group of studies looking at adjuvant therapy in colon cancer, so stage 2 and 3. And the question really was, is 3 months as good as 6 months? And let's give FOLFOX 3 months, FOLFOX 6 months, CAPOX 3 months, and CAPOX 6 months and see what's better. And so they had presented this a while ago and learned that we can do CAPOX times 3 months with less toxicity and great outcomes. And that's been now, all the way to survival benefit. But the IDEA data were reanalyzed this year at ASCO, looking specifically at young patients, right? So young onset colorectal cancer is on the rise. That's why the screening guidelines were lowered to 45. It's obviously a big issue affecting us, and we don't know why it's happening. And there is this question as to, is the biology different? Is something else changing? Like, why this is happening, and how do we treat our patients? And most of the studies that we looked at, including what we looked at pretty extensively at Memorial, we didn't see a difference in terms of response to chemo, in terms of outcomes in stage 4 disease, and SEER database sort of confirms that as well. But the IDEA data specifically asked the question of stage by stage, what are the outcomes and what is the toxicity, which is really nice because they had this prospective toxicity. And so what they found is that young patients did have more GI toxicity, so more diarrhea, more things where you have to kind of ask the questions to get an answer, and less hematologic toxicity. So their blood counts were fine, but they did not do better with chemo, but they tended to get more chemo. And then importantly also, in the very high risk, they had a worse disease-free survival, meaning that the cancer tended to come back at an increased rate in young people. And why that is not really clear. And so, the bottom line from that, I think, is like they were overtreated. They had worse toxicity, but yet still the more chemo didn't really make a difference. And so I think it sort of opens up more research questions, but to me, it also teaches us that CAPOX for 3 months is good in the adjuvant setting, and that really we should, think about our patients, not just by age, and try to be as aggressive as possible with chemotherapy, because we're not necessarily improving outcomes. In fact, it looks like we're not, but we are causing more toxicity. And that's particularly true in advanced disease where, quality of life really matters. I mean, it matters for everybody, of course, but when we're really thinking about not only duration, but also maximizing quality of life on treatment.
Right. All right, I just copied one over for you into the chat as well about, and I can put it up on screen even. We're having fun with Hopin today. So go ahead and take a look there, and then we can have you answer that one as well.
Yes, so the question was, biallelic MUTYH positive, is there any evidence for immunotherapy? No, what we know so far is just what the tumor looks like, and that's how we know immunotherapy works, meaning MSI-H tumors are hypermutated, so there's lots and lots of mistakes being made, lots and lots of neoantigens or flags for the person's own immune system to recognize the cancer as foreign. And then when we give immunotherapy, we see activity because the immune system is already engaged. And so that's why these Lynch syndrome, MSI-H tumors, where there's the defect in DNA repair, and they make so many mistakes and the tumors look so foreign, that's why it works. So really, if it happens to be an MSI-H tumor, that's really the key for now. But soon, hopefully very soon, there's so much research going into trying to convert MSS tumors where there's just not that many mutations, where it just doesn't look foreign enough to the immune system, into something that our own immune system recognizes as foreign, so that then immunotherapy will work. And that's really like the big area of research now, where we will definitely make progress and make that happen. it's just taking us a little while, but we'll get there.
All right. And does a diagnosis of colitis or Crohn's disqualify a patient from certain trials?
That's a great point. So yes, it disqualifies mostly from immunotherapy, again, because colitis, Crohn's, it is a disease of the immune system. The immune system is overly active. The immune system is attacking the colon. And when we give immunotherapy, it just takes the brakes off of the immune system. So then you get this extreme response in an immune system that's already attacking the healthy colon cells, and can be very, very, it can be lethal and dangerous if you have this profound diarrhea where the immune system is just going crazy and it's uncontrollable. So that's why many patients are excluded with a history of colitis. We've learned in patients, particularly in melanoma, and that's been published, that have gotten immunotherapy off trial, that even patients in colitis actually do okay. But because of trials are, very strict in terms of first and foremost, doing no harm, preventing toxicity, it's usually an exclusion criteria for immunotherapy studies, but not many others. But of course, it depends on, the mechanism of action of the drug and what the study's doing or asking, or utilizing, I should say, which drug.
Okay. And do signet ring colon cancer cells get treated any differently?
They don't. They make us a little bit more nervous because they tend to be more aggressive. Usually also with that comes a better response to therapy. They're just more sensitive to therapy, but we don't at the moment have any different protocols or any different treatment options. And we wouldn't give more aggressive therapy just because of signet cells. I think we would be a bit more nervous, and watch a bit more closely perhaps, but we wouldn't do anything differently.
Okay, then finally we have time for one more here. How do you see liquid biopsies changing the course of treatment options?
Great question. So, it's a little bit of a point of discussion for us in academics, because we're doing them. They're approved standard of care. People get them, but we don't quite have the data or the studies to be able to know how to react to circulating tumor DNA. So there are important ongoing trials looking at whether circulating tumor DNA in, let's say, stage 2, which I mentioned is a little bit of a struggle. Do we give chemo? Do we not give chemo? Whether circulating tumor DNA makes a difference. If we act on it, does it make a difference? Now we're getting it. We're collecting the data. For me, most of us, I should say, we note it. It's almost like a fancy CEA. If it goes up, you get a little bit more nervous. You think about doing a scan, but we wouldn't change treatment at the moment just based on circulating tumor DNA. We'd want something measurable because we're limited really in our drugs and in our ability to eliminate that circulating tumor DNA. And it gets a little bit tricky too, because it's not so clear in many cases that the circulating tumor DNA would do any harm. It might be cleared anyway, especially in certain subsets. It may not even represent the tumor. And so there's a lot of questions that I still think need to be answered. I think eventually it will replace probably CEA at the very least, as a marker, but I think we're still kind of learning what to do with it. But it's very difficult because many people get it, many people ask for it. And then we're just kind of like, okay, it's a data point, let's keep going with what we're doing, because again, we wouldn't change anything based on it because we just don't have the tools really.
Excellent. Well, thank you so much again. For those of you out there, if you still have more questions, go ahead over to fightcrc.org. Check out some of our resources there. You could also email patientinfo@fightcrc.org, and we'll get that passed along to one of our great partners like Dr. Cercek here to help get you the information that you need. So once again, thank you, Dr. Cercek. Thank you to all of you for joining us for today's webinar. You can always come back and check out the recording later. And thank you to our sponsors for this webinar, No Shave November and Genentech. So everyone have a wonderful Tuesday, and we'll see you next time.
Thanks so much. Bye, everybody.